Welcome, everyone, to the Arthritis Foundation's OACS conference. This is day 3, our final day of our inaugural conference. My name is Jason Kim, and I'm the director of OA research programs at the Arthritis Foundation. With OACS, we're trying to bring together researchers, investigators to help drive conversations about the progress toward new developments in OA clinical research. We're at the finale of the final season of OACS and have had great discussions that you can now check on our website and video sharing platform that will drop in the chat box at this point. You can check for latest updates to our program, the uploads of video recordings, as well as um, what we're planning for 2021. This conference features forum series sessions that you may have seen before, together with some speakers and video posters. Our conference lineup is excellent, and it's all thanks to very thoughtful chair, Tuhina Neogi. And of course, you've seen our forum series sessions that are that were arranged by David Felsen and Martin Lotz. But before I initiate the meeting with some opening comments by our CEO, Ann Palmer, let me remind you of a few housekeeping items. OA is a disease without borders, and we're proud to include many nationalities on this call. So that we can make this program available to people in all corners of OA research, the program is being recorded and links will be posted on our website in the coming weeks. Attendees can submit questions to the moderators, speakers, panelists, anytime via the QA chat function, but you will otherwise be muted. If you have any technical issues while on the Zoom call, please send an email to afscience@arthritis.org. Our staff will be monitoring the email line. Now I'll pass off to Ann Palmer, who will just give us some opening comments and initiate the meeting. Thank you, Ann.
Well, hello, everyone, and thank you, Jason, who's not just the director, he's the VP, so he has a new title. I'm surprised he hasn't used it. But it's my pleasure to welcome you, to greet you, and to be a part of the third day of this conference. Osteoarthritis is such an important topic, and it's not just because of the prevalence of osteoarthritis. But it's about the cost of healthcare to deal with this disease, and the fact that it affects so many people and is going to affect so many more in the future. I often speak of it as the tsunami of healthcare and healthcare costs. So it's such an important topic for us to deal with and to understand and to make progress in, and not just because of the cost and the prevalence, but also the significant impact that it has on the quality of life for people with osteoarthritis. I understand this personally, as I've had a double knee replacement myself as a result of injury, and just last year had some significant spinal surgery from arthritis as well. What I want you to know is that the Arthritis Foundation takes this seriously, and we're committed to leading the fight. The fight to create an environment that can ultimately lead to the introduction of a disease-modifying drug by working and lobbying with the FDA and to understand new endpoints so that we can develop progress, but also ultimately to understand
Sorry, everybody, for the technical issues. Hopefully Ann will be on again in a second. But if not, maybe we can prep David to initiate the meeting and introduce Kurt. Okay. Yeah, it looks like we're having some trouble there. David, could you help out? Thank you.
Yeah. Hold on a sec. So it's my pleasure to introduce Kurt Spindler, who's one of the world's leading clinical researchers in orthopedics and is vice chair of research for Orthopedics and Rheumatology Institute at the Cleveland Clinic, and has a number of other important managerial titles there. Kurt has led the NIH-funded MOON cohort for a number of years, which has provided us with invaluable information on the natural history of injuries to the knee and how they evolve into osteoarthritis. And he's going to lead our discussion of cohorts and the insights they've provided into osteoarthritis. Kurt, welcome.
Thank you. It's certainly an honor to be here, and it's a privilege to be here. And it's one of the topics that are near and dear to my heart, because not everything can be answered or should be answered in a randomized trial. And I think one of the things that we want to point out and have a discussion on, when is the most appropriate study designed to use a cohort study to provide information that you need in order to improve outcomes and improve patients. And I think if we can get that message across and see what we've learned and how that has helped impact patients, I think that would be very valuable. So we're going to try to be a little aggressive here. We're going to try to have, we have a number of speakers that are truly outstanding, and we want them to just give a little high view oversight of their area of research and what they've learned from it from a high area, and then maybe ask a question or two, and then we'll come back to the questions at the end. So what person I'd like to lead off is Rick Wright, who is intimately knows Moon. He's been a part of Moon since the beginning. Has been my right hand. And Rick runs the NIH-sponsored MARS, which is revision ACLs, which has a much higher, he'll tell you, prevalence of having post-traumatic OA. So with that, I'll let Rick is the chairman at the Vanderbilt Orthopedics in Nashville, Tennessee, and I'll let him begin.
Thanks, Kurt. I'll pull up my slides and get started. I appreciate the chance to talk, and as Kurt said, we've had a lot of success with cohorts. It's not the best way to answer all questions, but it has worked well for us. And this will be mainly about MARS because of the arthritis angle, but Moon led to MARS, which you will see. So we found that revision ACL reconstruction consistently had worse outcomes, patient-reported outcomes, just about any outcome measure you want to look at than primary ACL reconstructions. It was the consensus of the people that came together to form MARS and wanted to study this. Kurt and I wrote a couple and did a couple studies together where regardless of any other factor, if you had a revision, it was the strongest predictor for a worse KOOS score. Then we looked at 5-year outcomes of primary and revision ACL reconstructions, and the sheer fact that you had a revision was the most significant predictor of a worse outcome. But there was really an unbelievable lack of any good revision ACL data. There was really no level 1 or prospective studies that had evaluated why this may be occurring. So we had success with a prospective longitudinal cohort in Moon. And we know that in our cohort, when we were doing multivariable analyses, that we needed 10 to 15 subjects for every variable that we included. And with revisions, there's significantly more potential variables than in primary ACL reconstructions. You've got just a lot more going on in these patients, and so we knew we needed, a lot of patients, and we knew that 10% of the Moon cohort was revision. So if we were ever going to get numbers high enough, it was going to take a bigger effort than Moon from a standpoint of surgeons involved, because even busy sports surgeons like Kurt or people that you know around the country may only do 5 or 10 revisions a year. It's only going to be, even in a busy practice, about 10% of their ACL reconstruction. So as we say, a single Moon wouldn't do it. 90%, over 90% have either grade 2 or worse articular cartilage pathology or a meniscus tear. and 60% have both. So this is a beat up knee cohort that is already demonstrating at the time of revision a significant amount of articular cartilage damage, arthritis, however you want to think of it. So this is really a big factor for these people, and we believe a big part of the reason they don't do as well. So this cohort is a significant osteoarthritis cohort, much more so than the primaries. We've analyzed, and we're currently in the process of submitting our analysis of articular cartilage pathology at 6-year follow-up. So we have 1,234 patients that enrolled in the cohort, and we now have them all 6 years out, and some of the cohort has now reached 10 years out, but we've been able to finish the 6-year analysis of the entire cohort for its impact on patient-reported outcomes, Mark's activity, KOOS, and WOMAC. And as you can see, and these are p-values of negative or worse outcomes in these patient-reported outcomes. And as you can see, probably interestingly, the most significant area that results in patients feeling worse or reporting worse outcomes is in the patellofemoral joint. The patella and the trochlear groove consistently predict worse activity scores, worse quality of life scores, sports recreation, stiffness, pain on the WOMAC. So what we're finding is that articular cartilage damage that we identified at the time of revision at 6 years now is really resulting in worse patient-reported outcomes. So our ability to figure this out, deal with it, potentially address it more appropriately at the time of revision reconstruction could definitely impact our patients' outcomes as we follow them after surgery. So that's a quick overview. Kurt had asked for just a quick overview and a little bit of a highlight. So I'll end with that and look forward to hearing the other speakers and happy to answer any questions.
Is there any quick question for Rick that people want to ask right now? While you're thinking about that, Rick, what is the most important aspect you think in learning from the cohort? What did the cohort model teach you in Mars or in Moon for that matter?
Well, we've learned a lot. I think what we learned is that using the cohort model, we can include so much more data, variables, and I think that for many of us, the most important question was graft choice, because we weren't sure what graft would work. In fact, you and I kind of approached it differently, and neither one of us knew, if one was right or wrong or better or worse or whatever. And so we were able to, if we had randomized graft choice, I think we know in orthopedics it immediately results in a less than 50% participation rate. And we had a 98, 99% participation rate. And our graft choice laid out where it was 25% bone, tendon, bone, and soft tissue allograft, and 25% in each group, and 50% overall autograft, hamstrings and patellar tendon. And so we had 1,200 people really divided up into 4 equal groups, 25% each, and could really address that question. And we probably would have never gotten even 300 or 400 participants if we'd done a randomized trial. So I think, and the ability to include 75 other variables on top of graft choice is probably what's been most satisfying, the ability to answer multiple questions with one study.
So that 2 questions. One was, are reduced outcomes compared to primary reconstructed patients or compared to baseline? And came in on the chat.
Let me look at the chat.
That's the one from Josh Stefanik.
Yeah. Cartilage lesions in the patellofemoral joint. The incidence actually is fairly equal across all 3 compartments, slightly more common in the patellofemoral joint. what this says is that when it's in the patellofemoral joint, at whatever rate, it more commonly will cause worse outcomes. That when you have it, your patient-reported outcomes will go down, and it was a stronger predictor of a worse outcome than similar disease in the medial femoral condyle or lateral femoral condyle or tibial plateaus.
Rick, this is Lynn. Just real quickly, was there a difference by graft?
Yes.
This is part of what Josh is getting at because he's studying this.
Yeah. So at 6 years, odds ratio 3.78 times higher rupture rate with an allograft versus autograft.
Oh, no. I'm sorry. I was asking about the patellofemoral OA.
Is there a difference in the, you said
By
graft.
graft for in the disease in the patellofemoral joint?
Is there a difference in the graft? No, we have not seen a difference with allograft or autograft. And in fact, Chris Kading has looked at that too. And interestingly, frequently you'll see more patellofemoral disease with an allograft. So we have not noted a difference in incidence of chondral lesions.
Patellofemoral, yeah, awesome. Thank you.
Okay.
So our outcome scores typically are 10 to 15 points below what a primary would be, which exceeds the minimal clinically important difference for every score we looked at. There's really not a revision study out there where the patient-reported outcome scores would equal those expected with a primary. And the other question, how many years after primary ACL reconstruction was the 6-year follow-up? So the average time from primary to revision was over 2 years. And then the follow-up, the 6-year follow-up I'm talking about is from the point of revision ACL reconstruction. So 6 years after the revision, and across the cohort, the median was about 2.6 years after their primary reconstruction.
All right, thank you, Rick. If you appreciate that, we can very much move on to our next speaker. I think the next speaker we have Neil Segal will talk about his experiences. Is that right, Jason?
Yeah, that's right. We're just loading up Neil's presentation.
And his experience looking at structural changes in imaging related to a large cohort.
Thank you. Just going to go to my screen, the screen share.
And yeah, while we're waiting, is there anything that someone else wants to ask? So like the last question Rick answered was the 6 years is from the revision ACL, not from the primary, but the revision usually, as he stated, was about 2 years on average after the primary, the revision occurred.
Is my screen share working?
Yes.
Thank you.
We just see thanks for watching on Keynote Live. We don't see the slides.
Sure. Thank you.
Is that coming up?
Tim, are you asking a question? Oh, it's coming.
Yeah, I want to know how you guys got so good at acronyms. Was it luck, or did it take a lot of work?
It was luck because the moon was named for it was a write-in candidate. We had all these lousy names for the group, and then someone wrote in Moon, Multi-Center Orthopedic Outcome Network, and then it went from there, and then it became Meteor. Jeff Katz did Meteor, and then we did Mars, and now we have Comet as part of Arthritis Foundation. So it all started with something, and it's all gone crazy.
Don't you have Venus too, or something like that?
Well, we had Pluto, but that failed. But that's like a planet, not a planet.
Not a planet.
So that makes
oh well, they don't all live, right?
Every year, every 10 years, we change whether Pluto's a planet or not. Probably like the study's never going to be done.
Hey, Neil, is it fine if I share the PDF version that you gave me?
The PDF doesn't have all of it. Is it still not coming up?
No?
Yeah, it looks like we're hung up on this Keynote Live thing.
Could you share a new link with me and maybe try that? It might just be that you already had run through it.
Sure. Let me exit the slideshow then.
Okay.
I see that you're on it, so I don't think it's a new link.
Okay.
Worked when we tried it before.
Of course.
Technology.
It
sometimes
did. I
works,
saw your
sometimes
slides,
doesn't.
Neil, honest.
So one of the things that we learned from one thing about cohorts, and I think Lynn Snyder-Mackler will talk about that, is a cohort really looks at, there's certain things where certain conditions or diseases where you can't randomize things. And for example, on ACL reconstruction, or one of the good models for PTOA, you can't randomize who gets a meniscus tear and who gets articular cartilage injury. Nature's randomized that. So that's where a cohort's great design. Go ahead, Neil. I was just trying to fill time.
We can see it now. We can see it now. Thank you.
Excellent job. So the title slide came up now.
Yes.
Well, thank you so much to the Arthritis Foundation and the OACS organizers for the opportunity to present our research today. I'm presenting on behalf of a large team. Some of the key organizers of this study are shown on this slide, but it takes a much larger group to make a study like most happen. It's been a very successful study. I'm aware of 184 manuscripts that have been published to date, and over a dozen are currently being drafted. So the Multicenter Osteoarthritis Study, or MOST, is a National Institute on Aging funded prospective longitudinal observational study of people with or at increased risk for knee osteoarthritis. The goal is to identify risk factors for osteoarthritis, and for those with the disease to identify modifiable factors that might reduce the disabling impact. Among the risk factors for disease, MOST has focused some of its examinations on physical activity, systemic as well as local inflammatory factors, muscle weakness, meniscal tears, nutritional factors such as magnesium, vitamin D, E, and other, leg length inequality, and body composition. Among these, quadriceps weakness, synovitis, leg length inequality, high bone mineral density, and meniscal tears, even when asymptomatic, have been shown to increase disease risk. As I mentioned, this is a longitudinal study. The first portion of MOST took measurements at baseline and 30 months and had a telephone visit in between at 15 months. The second portion of MOST had added a 60 and 84-month visit, as well as a 72-month telephone follow-up. And then the third portion added 144 and 168-month visits, also with 152 and 160-month phone calls, where we collected things like WOMAC and KOOS and other important factors. I'd also like to mention that the retention for MOST has been excellent, with over 91% retention of contacts at the 84-month visits. That's over 91% of those who are still living. At the beginning in MOST, at baseline recruited 3,026 men and women age 50 to 79 years old from the general population surrounding Iowa City, Iowa, and Birmingham, Alabama. Those are our two clinical centers. We also have a data coordinating center at the University of California, San Francisco, as well as a data analysis center and X-ray reading center at Boston University. Numerous measures have been taken, which a full report of it doesn't fit within these 3 minutes. But we had imaging measures, joint position sense, biospecimens, physical examinations, In the second portion of MOST, we started drilling down more on quantitative sensory and vibratory positions, perception thresholds, also looked at muscle coactivation, balance and falls. And then in the third portion of MOST, in addition to we'd started with the 3,026 members, and we brought back 2,029 members of the existing cohort and added an additional 1,525 new members of the cohort at the 144-month visit. It's also interesting to note that over the 168 months we've followed the cohort so far, there have been 1,071 knee replacements. Many findings have kind of met of most. So again, it doesn't fit within the 3 minutes, but I thought I would focus on quadriceps weakness, which is one area that we've studied. Quadriceps weakness has been shown to increase risk for symptomatic knee osteoarthritis, osteoarthritis progression by joint space narrowing, worsening self-reported function. Adam Kulvinar and Joff Stefanik found increased risk for worsening lateral patellofemoral cartilage damage. Jose Rubio, Devyani Misra, and others also found radiographic and symptomatic knee osteoarthritis increased risk synergistically with obesity. And Catherine Bacon, Britt Allen Oisted, David Felsen, and others have looked at the effect of quadriceps weakness on physical performance being related non-linearly. Interestingly, all of these findings were found in women, but not in men in the cohort. We've also drilled down on these findings to see, are these findings explained by muscle mass, joint position sense, or other aspects such as coactivation, and those factors haven't been explanatory. It's been very helpful to have such a large study over such a long duration to really drill down on some of these questions and subgroups within the cohort. We'd like to acknowledge the 4 centers and grants that have been funded by National Institute on Aging. The most staff and participants have been so loyal to the study and donating their time and effort. And the most data, although it's mostly been looked at by internal investigators, is available online. So you can look for that at the link below if you'd like to study this cohort as well.
Thank you for that great high-level summary. Are there questions from the audience that we can take now? So what is the one biggest surprise that you've found in the study that you didn't expect to see, Neil?
Well, I mean, I think there have been a lot of surprises. I mean, one thing that I mentioned was that it started out being a study looking for risk factors for who's going to develop osteoarthritis. And so only a third of the cohort had OA at baseline, 2/3 we were waiting to see if they developed it. And over the duration, it's sort of turned into a really great observational study of risk factors and who's going to go for TKA, because a third of the cohort ended up going on to that so far.
Great. I don't see any, I'm sure there'll be more questions that'll come up.
I think it'll be good if we talk over one of the things that you guys have really shown that has certainly been my, I don't know, pet peeve's not the right thing, but like my target for rehab is quad strength being such a big player. Mm-hmm. And the good thing about looking at this across these, your cohort in particular, it's very large, is that's something we can fix, mm-hmm. right? We can't fix a lot of other things, but we can fix that. So,
right.
The fact that it just consistently still keeps coming up as such a big player, I think is very exciting from a rehab perspective, which is my bailiwick, obviously, that it is something we can alter. It's also, so I don't know how the surgeons
obesity, it's the only modifiable risk factor that has really been found so far.
Yeah, and it's probably easier to modify than losing weight, you know, from speaking from personal experience. it's nice to hear that. There's a couple of these players that just keep rising. Sorry, I gotta put my video back on. That just keep rising to the top. Quad strength seems to be one. Getting full knee extension back after an intra-articular knee injury. Those all seem, they're all fixable.
Mhm.
So Neil, there's a question from someone you know very well in the chat box. Can you see the chat box?
Yeah, I see it. So the main inclusion factors for the original incarnation of MOST were pain on most days of the prior month, being obese or overweight, or having either a knee injury or surgery in the past. When we went to the newer cohort, then there were additional factors. So we were actually looking at younger people. So we went down to age 45. And also we're looking for people who had minimal pain and KL grade less than 2. So we really focused on who didn't have pain or OA yet and who's younger, because of course it's of great interest to diagnose risk factors earlier and, deal with this disease before the cat's out of the bag, so to speak.
Okay, terrific. Thank you. Let's move on to our next speaker. Tunisia will talk a little more about OA from a little different perspective, from maybe the perspective of pain, and correlating pain and imaging is always a very, very dicey criteria to do. So,
Great.
welcome. Thank you.
Thank you, Kurt. So we all know about the structure symptom discordance, and as Kurt just said, it can be quite dicey. And we've understood that this is largely because of the fact that pain is multifactorial. And because pain is multifactorial, disentangling joint pathology, the relationship of joint pathology to OA pain has been challenging. But many of you know we've used a method of a within-person knee-matched approach to try to disentangle this. But what I decided to do today to focus on in my 3 minutes is on these neurobiological mechanisms. Sorry, can't see the arrow here. To focus on the neurobiological mechanisms that can contribute to the pain experience in osteoarthritis. So we've taken an approach of looking at neurobiological mechanisms by focusing on peripheral sensitization, which refers to alterations in peripheral nociceptors. And we can assess this functioning with using a handheld ergometer to measure pressure pain threshold. Central sensitization refers to alterations in the neurons within the central nervous system. And we can assess this with temporal summation, which we do by using a series of weighted probes. And if the pain increases after that train, that indicates there's temporal summation. And both of these are functioning of the ascending pain pathways. And then there can be descending inhibitory modulation. And we have a protocol for this, but unfortunately 3 minutes won't allow me to review those findings. So first I'll share the pressure pain threshold and temporal summation result being associated with pain severity. When we used the handheld ergometer, we found that those with the lowest pressure pain thresholds at the knee, meaning they're most pain sensitized, they had a higher risk of having frequent knee pain and more knee pain severity. And so this indicates peripheral sensitization. We found a similar result at the wrist, a distal site unaffected by OA, and that indicates central sensitization. For temporal summation, again, this using the series of weighted probes, we found that temporal summation present at the wrist or patella was associated with pain severity. And interestingly, contrary to our hypothesis, was not associated with radiographic OA. We've also been interested in understanding whether specific pathologies contribute to sensitization. And we found that bone marrow lesions reflecting mechanical issues were not associated with sensitization, whereas inflammatory lesions such as synovitis and effusion were associated with sensitization and increased the risk of its development. And then the final study I want to share with you is work that Lisa Carlesso did with me when she was a visiting fellow on pain susceptibility phenotypes. We were interested in why some people only have intermittent activity-related pain, whereas other people can develop persistent knee pain. So we looked at people who are free of persistent knee pain, and we wanted to know if there were features or clusters or groups of characteristics that predispose them to developing that persistent knee pain. And so we performed a latent class analysis and agnostically identified 4 different classes. One of the classes was largely dominated by having low pressure pain thresholds, meaning they were pain sensitized. Another group was dominated by having temporal summation. And then the other 2 groups had lesser degrees of sensitization. What really surprised us was that there was no difference between these groups in widespread pain, pain catastrophizing, depressive symptoms, or poor sleep, basically very similar across the groups. So remember, these were people who were free of persistent knee pain at baseline. Over 2 years, when we look at these 4 groups, we found that this group that had pain sensitization by pressure pain threshold had a 2-fold increased risk of developing persistent knee pain over 2 years, indicating that pain sensitization can predispose to developing persistent knee pain. So that was a very quick high-level summary of some of our published findings. QST measures are associated with pain severity, irrespective of radiographic severity, are associated with specific inflammatory pathologies, and have an important role in pain susceptibility. And with that, I'd like to acknowledge the funding. Neil outlined that most data are publicly available, and I'd be happy to address any questions. Thank you.
So hopefully people put something in the chat box. What was the most surprising finding that you observed or didn't expect to see?
Yeah, so I know I had to do that very, very quickly, but we modeled our studies of pain sensitization in thinking about how pain sensitization occurs in animal models. In animal models, joint injury or chronic inflammation can lead to sensitization. Now, we cannot do electrophysiologic studies in humans. We can't interrogate their spinal cord and the nerves. So we use these QST measures as a proxy for understanding those mechanisms. So what I was most surprised by is that we hypothesized that the more severe osteoarthritis, the longer duration of osteoarthritis that one has, they would be more likely to be sensitized. We thought this was a state that could be induced. If you have enough peripheral stimuli, enough peripheral nociceptive input, you get sensitized. We did not find that. And in fact, the pain susceptibility phenotype shows that people have sensitization pre-existing that can lead them to develop different pain experiences. So this indicates that pain sensitization is more like a trait that someone is inherent to someone potentially and gets manifested once you have pathology. There's a question from David Felsen in the chat. Does pain sensitivity account for post-knee replacement pain? So this was another big area of interest for us. 20 years ago now, there was a report of people after hip replacement having normalization of some of these altered pain mechanisms. And there was a more recent report in knee replacement participants, but these were very small studies of 13 and 20 people, and they all had pain improvements post-knee replacement. And we know that about 20 to 30% of people have persistent pain post-knee replacement. So we looked at this in our larger MOST cohort, and we found that if someone had evidence of temporal summation, which is an ascending pain facilitation indicator, or they had inadequate descending inhibition, meaning they have inadequate dampening of pain signals, they had worse pain post-knee replacement. So while post-knee replacement pain persistence may be multifactorial, at least some component is driven by these central nervous system mechanisms.
How would we dissect out the contributory factors to pain in people everyone has significant knee OA? So you have individuals that we all see that have at least radiographic, which is a very crude way of looking at it. They seem to have the same, maybe they're all KL3, but they seem to have very different levels of pain, even when you look at the MRI. And how do you account, what things you think are going on that account for that person's level of pain? Could you?
Yes, I think that's a really important and fundamental challenge in osteoarthritis. So in my first slide, I indicated that pain is multifactorial. And so we know as clinicians that if we don't address sleep and mood and coping skills, then they may not get as much symptomatic benefit as someone else who doesn't have issues in those regards. For many years, people have been advocating for a mechanism-based approach to OA management. And so what are the tools that we have to identify what is at play in an individual? So we are really still without clinical tools to assess this.